All right.
Welcome, everyone, and thank you for taking the time to watch and listen to our debate. I'd like to start by introducing everyone in the group and what our roles and jobs are throughout the debate. My name is Jessie, and I'm introducing the debate, and I will also introduce and talk about our pro side of the argument, which is ABA. Angela is the summarizer for the pros. Mandy is the summarizer for the cons. Katie is the researcher for both sides, and Christina is the illustrator for both sides. And finally, Adrian is the fielder and will answer the questions at the end. Applied behavior analysis is an intensive behavioral therapy that has been proven to show functional improvements that last in individuals with autism spectrum disorder. For this reason, ABA is considered the gold standard of treatment for individuals with autism in most of North America. There have been several long-term and large-scale studies done that show that children who receive at least 25 hours of ABA a week for 1 year will make tremendous gains. Some participants even achieve functioning within the average range for their age. ABA programs that are used for individuals with autism are supported by a significant amount of scientific evidence. However, even though ABA has years of empirical evidence, some occupational therapists, parents, teachers, and others favor alternative approaches like sensory integration and the medical model. We will be debating why ABA is better than the alternative models of sensory integration and the medical model. Our debate is informal, and here's how it will work. We will start with the medical model. Angela, the summarizer, will explain the pros of the medical model. Then Katie, the researcher, will give some research behind the pros of the medical model, followed by Christina with illustrations. Once the pro side of the medical model is complete, Mandy will step in with the negatives or the con side of the medical model and why ABA is a better option. Katie, the researcher, and Christina, the illustrator, will also add some points against the medical model and why ABA is better. Once the medical model is complete, we will follow the exact same format for the sensory integration method. I hope this helps you follow along during our debate. We will again introduce ourselves and our roles as we go so you can follow along. I will now turn it over to Angela, who will begin the debate with the pro sides of the medical model.
The medical model holds that mental illness is a psychiatric disease with a physical explanation and therefore can use medical treatment. This model views behavioral abnormalities in the same framework as a physical disease or abnormality. Essentially, it treats mental disorders in the same way that something with a known physical cause would be treated, such as a broken arm. Supporters of this model consider symptoms to be outward signs of the inner physical disorder. With this, it is believed that if these symptoms can be classified into a syndrome, then the true underlying cause can be determined and appropriate physical treatments can be delivered. The medical model addresses symptoms of autism through the use of medication or medical treatment. Medication is often recommended to decrease symptoms of comorbid disorders such as anxiety or depression, especially when behavioral therapies are not showing results. Medication can be easy to use, convenient, and show improvement of behaviors and skills quickly. It has been shown to improve social skills, increase focus level, and retain impulsivity, among other characteristics that are known to be common in autism spectrum disorder. And now Katie will present the research behind the medical model.
The first article that supports the medical model as an effective treatment for symptoms of autism is Antipsychotics in the Treatment of Autism by Posey, Stigler, Erickson, and McDougall. The article discusses that the use of atypical antipsychotics frequently used to treat symptoms of autism, such as irritability, aggression, self-injury, hyperactivity, and stereotypical behavior. The first antipsychotic discussed was risperidone. In one of the studies reviewed, risperidone was successful in improving behavior in 8 of 14 adults with autism or PDD, according to the Clinical Global Impression Improvement Scale, whereas the placebo group did not see any improvements in behavior. A pediatric study conducted by the research units on Pediatric Psychopharmacology Autism Network was also reviewed. In this study, 101 children and adolescent participants with a mean age of 8.8 years, there were 101. The subjects were rated according to the Aberrant Behavior Checklist, and all showed a significant level of problem behaviors at baseline. The subjects were randomly assigned to a group and either received a placebo or risperidone for 8 weeks. 69% of the subjects receiving risperidone were considered treatment responders, and only 12% of the placebo group responded with a decrease in problem behaviors. Several other studies conducted using risperidone showed improvement in the symptoms of autism. These studies resulted in the FDA approval of the use of risperidone for individuals with autism ages 5 to 16 to treat irritability. Posey et al. Also reviewed the use of olanzapine to treat symptoms of autism and PDD. In one 12-week study, the use of olanzapine in children, adolescents, and adults showed a significant improvement in hyperactivity, social relatedness, sensory responses, language, self-injury, aggression, irritability, and anxiety and depression, according to results from the CGI. Ziprasidone was also reviewed, and one study showed improvement in the behaviors of 6 out of the 10 participants, and all 10 participants lost an average of 9.5 pounds over the 6-month study. Posey et al. Listed the limitations of the study, including the need for more studies to be conducted on the use of risperidone and other antipsychotics in less irritable children with autism. Risperidone was the only drug that proved to be consistently effective in the treatment of disruptive behaviors, so further studies on other antipsychotics need to be conducted. Additionally, further research must be done on the side effects of the medication. Christina will now present the visuals from this article.
The first visual was taken from the article by Posey et al., and it details the amount of medication, what medication, and what improvements and side effects were seen in each of the studies reviewed. Risperidone was the most commonly reviewed medication, and users saw an improvement in aggression, irritability, repetitive behavior, and social withdrawal across the studies. The study reviewing olanzapine saw a global improvement from participants, and quetiapine was shown to decrease aggression, hyperactivity, and inattention. Ziprasidone and aripiprazole were both shown to improve aggression and irritability. Katie will go over another article at this time.
The second article that supports the case for the medical model to treat autism spectrum disorder is the treatment of autism with low-dose phenytoin, a case report by Philip D. Bird. The study was conducted with a 19-year-old male as the patient who presented with ADHD and autism. The participant had a history of irritability, impulsivity, aggression, and difficulty with social relationships. Once he had been administered the phenytoin, within 10 minutes he reported that it was easier for him to converse with others and maintain eye contact. Over the course of the next 2 weeks, the subject's family reported that social interaction had increased and there had been no aggressive outbursts. Eventually, after the patient had been taking the phenytoin for 18 months, it was reported that he had developed peer appropriate friendships for the first time, and his violent outbursts had gone away. The author suggested that further studies with more participants be done to see if this carries over to larger populations. Although this was just a single case study, it does show that medicine may be effective in treating symptoms of autism, including social deficits. Christina is going to present the visuals from this article.
The graph from this article shows that the participant scores on the Depression Anxiety Stress Scale and the Autism Spectrum Quotient before and after the use of phenytoin. As shown, his depression score dropped from 25 to near 0, which is well below the clinically significant cutoff of 12. His anxiety score also dropped below the clinically significant cutoff of 14. While his stress score did remain above the clinically significant cutoff, it decreased dramatically after the use of phenytoin. Additionally, his AQ score dropped from 41 to 27, which is significant because a score of 32 or more means the subject shows clinically significant autistic traits. So he ended below that level due to the medication.
The final article I will discuss related to the pros of the medical model is hyperbaric oxygen treatment in autism spectrum disorders by Rossignol, Bradstreet, Van Dyke, Schneider, Friedenfeld, O'Hara, Cave, Buckley, Mumper, and Fry. This article discusses the use of hyperbaric oxygen treatment, which has patients inhale 100% oxygen while in a pressurized chamber. Hyperbaric oxygen treatment can be used to help with physiological abnormalities such as cerebral hypofusion, inflammation, mitochondrial dysfunction, and oxidative stress. Previous studies have shown that this treatment may improve mood, behavior, and social interactions in individuals with autism. This article reviewed several of these studies, and many have shown improvements in sensory problems, aggression, tantruming, and gastrointestinal problems. In one study, 69 children with autism spectrum disorder participated. 33 of the participants received hyperbaric oxygen treatment for 40 sessions over the course of 4 weeks, while the other 29 participants acted as the control group. According to the CGI scale, parent-rated CGI scale, and the ATEC scales, significant improvements in overall functioning, receptive language, social interaction, and sensory awareness were reported for the group receiving hyperbaric oxygen treatments. Christina will now present the 3 illustrations from this article.
These charts are from the stated article that reviewed the use of hyperbaric oxygenation as a form of treatment for individuals with autism. This first visual on the left is coloring pages completed by a 17-year-old with autism before and after hyperbaric oxygen treatments. The first picture on the top left is before beginning treatment. The top right picture is after 1 week of treatment. The bottom left picture is after 3 weeks or 15 hours of treatment, and the bottom right is after 5 weeks of hyperbaric oxygen treatment. The footnote on this visual notes that the individual's coloring skills remain stable after 6 months of the treatment. This participant also showed an improvement in speech skills as well as self-help skills over the course of the study. The second visual picture in the middle shows the handwriting from a 6-year-old before and after 41-hour hyperbaric oxygen treatment session. His handwriting is more clear and precise after the introduction of hyperbaric oxygenation as a treatment. The final picture on the left is a PET scan image from a 12-year-old boy with autism. These scans were taken before and after 80 hyperbaric treatment sessions. The white arrows point out the improvement in deeper cortical hyperfusion patterns. Red shows the midline cerebellum hyperperfusion improvements, and yellow shows the temporal lobe hyperperfusion improvements after the hyperbaric oxygen treatments. Mandy will now explain the cons of the medical model.
Although medication may show an improvement in behaviors and skills, there are a number of cons related to this method of treatment, with a variety of side effects, anywhere from mild to debilitating, which can make for a lesser quality of life for individuals taking the medication. Additionally, medical treatments can be easily discontinued by parents or individuals taking the medication. Katie will now take over with the research behind the cons.
One of the most significant cons related to the treatment of autistic symptoms with the medicine is the side effect caused by the medicine. In the article referenced earlier, Antipsychotics in the Treatment of Autism by Posey et al., many side effects were discussed. One of the studies reviewed indicated that risperidone caused at least one aversive side effect in 13 of the 15 subjects that participated in the study. Additionally, in the study conducted by the research units on Pediatric Psychopharmacology Autism Network, the subject receiving risperidone gained an average of almost 6 pounds over the course of 8 weeks, the 8-week trial, and an increase in drooling was reported in some of the subjects. Additionally, a study conducted on quetiapine began with 6 subjects, 4 of which dropped out of the study due to poor tolerance of the drug. Of the 2 participants that completed the study, both showed appetite and weight gain. Posey et al. Listed weight gain as the most significant side effect of the use of antipsychotics to treat symptoms of autism, especially in children and adolescents. It was noted that weight gain is a concern because it can lead to many other medical problems later in life. Other side effects were also discussed, which Christina will address with the visual.
Okay. While the pro side of this debate mentioned the improved symptoms as a result of medication use, it is also important to discuss the side effects. The studies reviewing risperidone noted sedation, weight gain, and hypersalivation as the most notable side effects. Olanzapine also caused sedation and weight gain. Quetiapine caused those side effects as well, while also noting increased agitation as a side effect. One study using quetiapine actually had a participant show increased aggression as a result of taking the drug. Ziprasidone and aripiprazole also caused weight gain in their participants.
Another evident concern related to using medication to treat autism is the fact that medication can be discontinued by the patient, family, or pharmacy at any time. In the study done by Bird, the 19-year-old patient discontinued the use of medication after 4 weeks and stayed off of it for 9 months. His behaviors returned to baseline levels of aggression and difficulties in social interaction. Additionally, at the start of the study, additional medication was recommended to help with his aggressive outbursts, but he denied this suggestion, saying that he did not care if he upset others with his behavior. The use of medication can be very unstable depending on the users and their families, as well as their circumstances. Inconsistent use of medication makes it a difficult treatment to maintain. Another negative to the use of medicine in the treatment of autism is that it is not able to significantly impact social skills or language skills in individuals with autism, which are often the most common side effects of the condition. Although the study by Bird showed some improvement in the subject's social skills, it was only a single case study, and there was no evidence that this would carry over to a larger population or a different age group. Additionally, in the article Treatments for Autism, Parental Choices and Perception of Change by Bowker, D'Angelo, Hicks, and Wells, the authors surveyed 970 parents of children with autism and other pervasive developmental disorders about their use of the treatments for their children. Of the treatments, medication had the highest rate of discontinuation. On the other hand, in that same article, ABA was reported to be the most widely used treatment among the survey results, and all reviews of ABA were high, whereas the reviews of medication were mixed.
Okay. And Bowker et al. Used this chart to detail the results of their study. Medication was the most frequently discontinued treatment option at a rate of 19.9%, or 281 people surveyed. This was most commonly due to a lack of behavioral progress or an aversive result of the medication. There were no reports of medical procedures being used to treat the symptoms of autism. Of the treatments parents reported using, ABA was the most widely used by 37% of participants. Medication was only reported to be used by 14.6% of parents surveyed. Jesse will now conclude the pros discussion of the medical model.
To sum up the medical model, medication can be used to decrease symptoms of comorbid disorders when other therapies are not working. Medication can be easy to use, it's convenient, and can show improvements quickly. It has been shown to improve social skills, increase focus level, and retain impulsivity, among other characteristics that are known to be common in autism spectrum disorder. However, there are a number of cons related to this method of treatment. Medication can come with a variety of side effects, anywhere from mild to debilitating. Additionally, medical treatments can be easily discontinued by parents or individuals taking the medication. And now we will begin to discuss the pro side of sensory integration, starting with Angela providing a summary of the topic.
Sensory integration therapy has been widely used and accepted by both parents and occupational therapists as an effective treatment for children with autism spectrum disorder. This therapy practiced by occupational therapists uses play activities in ways designed to change how the brain reacts to touch, sound, sight, and movement. This is often found to increase daily function. Sensory integration theory hypothesizes that difficulty modulating sensory information can result in sensory defensiveness and under or over responsiveness to sensory stimuli, which may present itself in a client as developmental, learning, or behavioral problems. Many occupational therapists choose sensory integration therapy, often a sensory diet, as a clinical treatment designed to help individuals process the sensory input received from their environment appropriately. In a survey of occupational therapists, 82% stated that they always use a sensory integrative approach for children with ASD. And 56% of parents stated that they had their child exposed to sensory integration techniques. Practitioners report 3 types of benefits from sensory integration therapy. They are enhanced ability to focus on materials, reduced challenging behaviors such as self-injurious behaviors, and improved nervous system functioning, resulting in improved language and reading. And now Katie will provide some of the research behind sensory integration.
The article Occupational Therapy Using a Sensory Integrative Approach for Children with Developmental Disabilities by Schaaf and Miller details the history of sensory integration. It was originally developed for children with learning disabilities by an occupational therapist, Jean Ayres, who believed that difficulty learning reflected a problem with neural functions, which, for some children, could be solved with help processing the sensory information they receive. Sensory integration activities aim to incorporate sensory, motor, cognitive, and perceptual skills. It has been noted that children with autism may be able to improve their play, academics, and social skills through the use of sensory integration. Since its development, sensory integration has been divided into 3 groups: sensory modulation disorder, sensory discrimination disorder, and sensory-based motor disorder. Each of these groups can be addressed through different techniques in sensory integration therapy. As of 2005, over 80 studies have been done to assess the sensory integration model, and about half show some effectiveness of the treatment. Although not enough research has been done to find a definite conclusion about the effectiveness of sensory integration, the authors believe that the field has tremendous promise. The article Comparison of Behavioral Intervention and Sensory Integration Therapy in the Treatment of Challenging Behaviors by Delvin, Healy, Leader, and Hughes compared the use of sensory integration treatment versus function-based behavioral interventions in addressing aggressive and self-injurious behavior. There were 4 male participants, all under the age of 12, who were diagnosed with autism spectrum disorder, which was accompanied by these challenging behaviors. Baseline data was taken and then an alternating treatment design was implemented with each of the boys for 10 days. The sensory integration therapy used materials such as a vestibular swing, trampoline, peanut-shaped ball, being wrapped in a blanket, deep pressure, tapping the body, chewing on a chewy tube, and/or joint compression. Behavioral interventions were developed individually for each of the boys based on the functions of their behavior. In 2 out of the 4 patients, sensory integration therapy decreased the rate of aggression from baseline.
Okay. This is the chart from the comparison of behavioral intervention and sensory integration therapy in the treatment of challenging behavior by Delvin, Healy, Leader, and Hughes, which compared the use of sensory integration treatment versus function-based behavioral interventions to address aggressive and self-injurious behavior. As you can see in chart 2 and 4, both participants had decreased rates of self-injurious behavior after sensory integration therapy when compared to baseline. Sensory integration therapy was effective for these 2 participants. Mandy will begin to explain the con side of this form of treatment and why ABA is a better choice.
We have a responsibility to recommend effective treatments based on empirical evidence. Current research on sensory integration effectiveness is inconclusive because many studies are not well designed. And the studies that were well designed showed that sensory integration therapy did not benefit the individuals receiving treatment. In addition to the lack of empirical studies to show the effectiveness of sensory integration, there have been studies that compare sensory integration treatment to behavioral treatments, in which sensory integration treatment was not effective. But behavioral treatments based on functional assessment have been proven to be effective. Here is Katie with the research behind the cons of sensory integration.
Delvin et al. Discussed the results of their comparison of sensory integration versus function-based behavioral interventions, which had mixed results. Behavioral interventions were more successful than sensory integration in reducing aggressive behaviors, which, according to Delvin et al., is consistent with previous research. The limitations of this study included the alternating treatment design, which could have interfered with the success of sensory integration therapy, although the authors did not feel this was a real concern. Additionally, it was recommended that further studies be done using more participants to compare both types of treatment.
For participant 1, sensory integration actually increased the average aggressive incidence per day to a rate higher than baseline. For that same participant, aggressive behaviors decreased on the days where behavioral intervention was used. For participant 3, there was no difference in the rate of aggression between baseline and sensory integration, so the treatment had no effect. It's important to note that for all 4 participants, aggression was reported at a lower rate on days when behavioral intervention was used, as opposed to days sensory integration was used. In fact, the behavioral intervention reduced the rate of aggression to 0 for one of the participants and near 0 for the other 3.
Another article, Sensory Integrative and Behavioral Therapies as a Treatment for Pediatric Feeding Disorders, by Addison, Piazza, Patel, Bachmeyer, Milnes, and Otto, also compares the 2 therapies. The study had 2 participants, a 1-year-old boy and a 3-year-old girl, both of whom were admitted to a pediatric feeding disorders day treatment program due to sensory issues with food consumption. An occupational therapist was brought in to design sensory integration treatments to use with each of the participants, and a behavioral intervention related to the function of escape was also developed. The results of the study showed that sensory integration was not successful in increasing the amount of food the children tolerated, and it also did not successfully decrease inappropriate eating behaviors. The behavioral intervention related to escape was successful in increasing appropriate eating behaviors. One limitation to the study was that non-contingent reinforcement was also available in the behavioral intervention, but not in the sensory integration. Sensory integration may have been made more effective with the combination of non-contingent reinforcement, but that would not have isolated sensory integration as the only intervention being used. Further research should be conducted. However, this study concluded that sensory integration was not an effective treatment for feeding issues.
Charts from a comparison of sensory integrative and behavioral therapies as a treatment for pediatric feeding disorders by Addison et al. clearly show behavioral interventions to be more effective than sensory integration therapy in this case. The charts on the top left and top right show the percentage of bites accepted by participants. The first participant had near 0% bites of food accepted, while the second participant had a variable percentage of bites accepted in both baseline and sensory integration treatment phases. In the behavioral intervention phase, which was escape extinction plus non-contingent reinforcement, both participants had nearly 100% bites accepted. When sensory integration therapy was implemented once again in a treatment phase, both participants' percentages decreased again, and when the final best treatment phase of behavioral intervention was implemented, both participants' percentages of bites accepted were nearly 100% again. Both participants also had a significant decrease in appropriate behavior per minute during behavioral intervention, as shown in the bottom two graphs.
To review, sensory integration therapy has been widely used and accepted by both parents and occupational therapists as an effective treatment for children with ASD. Many occupational therapists choose sensory integration therapy, often as a sensory diet, as a clinical treatment designed to help individuals process the sensory input received from their environment. The three types of benefits from sensory integration therapy are enhanced ability to focus on materials, reduced challenging behaviors, and improved nervous system functioning, resulting in improved language and reading. However, current research on sensory integration effectiveness is inconclusive because many studies are not well designed, and studies that are well designed show that sensory integration therapy did not benefit the individuals receiving the treatment. In addition to the lack of empirical studies to show the effectiveness of sensory integration, there have been studies that compare sensory integration treatment to behavioral treatments in which sensory integration treatment was not effective, but behavioral treatments based on functional assessments have proven to be effective. And now Mandy will tie things up for us.
ABA is considered to be the gold standard of treatment for individuals with autism spectrum disorder in most of North America. Not only has ABA been proven to show functional improvements that last in individuals with ASDs by researchers, it is also used by most clients and also had high reviews in comparison to alternatives. As indicated by the study, treatments for autism, parental choices, and perceptions of change. Although ABA has been proven to bring about lasting improvements through empirical evidence, some occupational therapists, parents, teachers, and others favor alternative approaches, such as the ones we have discussed today. ABA is the better choice when compared to sensory integration based on the fact that the studies lack empirical evidence and are not well designed. As behavior analysts, it is our duty to provide our clients with effective and scientifically supported treatment. Providing any other kind of treatment would violate the Compliance Code 2.09, which states that behavior analysts have the obligation to provide clients with and teach them about the most effective treatment that is scientifically supported. When all of the facts about each treatment are studied, ABA is the only one that has empirical evidence and reviews from parents of children with ASDs backing it up. And now we'll hear from Adrienne, who will answer questions.